Elevate your expertise in the pediatric cardiology field? Welcome to the Pediatric Cardiology Fellowship, a premier one-year online program designed to equip you with advanced knowledge in the pediatric cardiology field. Our aim is to provide you with high-quality educational materials and up-to-date pediatric cardiology scientific knowledge delivered by a panel of highly qualified international expertise. Our professional panel ensures that the curriculum is high quality, up-to-date, evidence-based, and well-structured. Why travel for training when you can learn from top pediatric cardiology experts online? Our program brings world-class instruction directly to you, no matter where you're located, through case-based discussions, Q&A sessions, virtual workshops, and personalized feedback. You'll receive high-quality education
that augment and complement your personal training,
all from the comfort of your home or workplace. Our pediatric cardiology program offers a comprehensive fellowship structured into 3 modules, 16 weeks each, with a total of 96 credit hours and in-depth training over 1 year period. Balancing work, life, and professional development can be challenging. Our Pediatric Cardiology Fellowship is designed with your busy schedule in mind. With self-paced learning modules and live virtual sessions, you can advance your skills without disrupting your clinical duties. This program allows you to learn and gain experience at your own pace. From mastering congenital and acquired heart diseases to specialized training in ECG, echocardiography, cardiac imaging, including MRI, diagnostic heart cath, electrophysiology and arrhythmia management, mechanical circulatory support, and cardiac critical care. You will develop the essential skills to manage children with various kinds of heart disease at any circumstances and healthcare setting. Upon completion, you'll earn an internationally recognized AACME accredited graduation certificate, helping you enhance your credentials, advance your career, and improve your patient outcomes. Join a growing community of pediatric cardiology professionals who have transformed their careers with this fellowship. Don't miss this opportunity. Take the first step towards mastering the pediatric cardiology specialty and transforming the way you deliver care to your sick children. Visit our program landing page and register to reserve your spot. Limited seats available. Don't miss your chance and register today.
Hello, everyone, and welcome to our Pediatric Cardiology Fellowship webinar. Today, have very special webinar. We have very special guest speakers and moderators. We have Professor Sahar Shakar Shata, Professor of Cardiology at Cairo University, and Dr. Abbas Kashmoud from United Arab Emirates. And we have great moderators, Dr. Najib Dadah from Montreal, Canada, and Professor Rima Badr from Saudi Arabia. So our focus today is fetal cardiology, from diagnostics to interventions. We are trying to bridge the gap between obstetricians and pediatricians and pediatric cardiologists. And here is a humble agenda. After this introduction, Dr. Sahar is going to start her first presentation. Dr. Rima is going to introduce Dr. Sahar. Then after that, we are going to have a couple minutes description of our fellowship program. Then Dr. Abbas will go for the second talk. He's going to talk about perinatal management and congenital heart disease. Then Dr. Rima and Dr. Najib are going to moderate the question and answer session. So, as you know, the first speaker, Professor Sahar Shaker, she is Chief of Division of Pediatric Cardiology at Cairo University, and she's going to talk about congenital heart disease, bridging prenatal diagnosis and postnatal catheter intervention. Her talk will be for 20 minutes. Then the second talk will be for Dr. Abbas Kushnood, who is going also to talk for about 20 minutes about antenatal diagnosis to delivery room action and beyond when timing defines survivals. Again, our great moderator, Dr. Najib Dadah from University of Montreal, Canada, and Professor Rima Badr, a professor of pediatrics and fetal cardiology in King Abdulaziz University Hospital. Housekeeping stuff here. If you have any questions, inquiries, concerns, please put it in the QA box. All attendees should receive certificate of attendance by next week. And if you want also to hear the transcription, to read the transcription on top of hearing the lecture, you can do this by activating or enabling the show caption option. With that, I'm just going to emphasize that all of this knowledge that we are trying to help with has no value except you adopt it and you apply it to your training, to your clinical practice, to try to improve your patient outcome, because the great aim of education is not the knowledge itself, but the action. With that, I'm going to let Professor Rima Badr to introduce our first speaker, Professor Sahar Shaker.
Hello, everyone. Do you see me? Because I don't see myself.
It's okay.
But I don't know what happened, but maybe the IT could help us. But let's not waste time. I'd like to thank Dr. Amr, Professor Amr, for the invitation. And I'd like to also welcome Dr. Najib, my moderator, and I'd like to welcome the speakers. So I'm going to present Professor Sahar Shaker, who is a known figure in pediatric and fetal cardiology from Egypt, head of department in Australia, with a lot of experience, over 30 years of experience across Africa and Europe and United States. And I'd like to give chance to Professor Sahar talk about the interesting topic in this webinar. Professor Sahar, could you please share your screen?
Thank you, Professor Rima. Thank you, Professor Amr, Professor Najib, Professor Abbas, for joining us and allowing me to share in this educational, marvelous webinar. And I will try to share my screens now and start. Can you see now my slides?
Yes.
Okay. Okay, my talk today will be around about bridging prenatal diagnosis to the post-catheter cath intervention. I'm the head of the Fetal and Pediatric Cardiology program, and I assume we are the biggest in Africa now. And we have a lot of referrals with the biggest tertiary center, and we do the fetal echo in advanced scanning and modalities, and with the postnatal catheter intervention. I'm so privileged to have this because when I see it intrauterine, it gives me a lot of expertise and scope of how to achieve my mission in the cath lab. As for an introduction, we do know that the congenital heart accounts for 2.4 to 12 per thousand live birth. It's the highest morbidity and mortality among all infants, around 10%.
Can you move the slides, please, Professor Sahar?
Yes, I am. At 12 weeks, it's the rise of a grain. but at around 20 weeks gestation, it's around the size of a coin. So just a quick history: when it started by the 1958 with a Lancet paper published by Ian Donald and his team at UK Glasgow. But then later on, at the end of the 90s, 1998, when Carvalho published her first moving heart and paper with all the sophistications and the anatomy of the congenital heart.
Dr. Sahar, please full screen.
It is full screen in front of me?
No, click it.
It's not?
Click it on the right lower button.
The what?
Click on the full screen.
There it is. It's not? Okay.
This is good.
Okay. So it's a blessing that we do know most of the congenital hearts are mild forms, but the one we're worried about are the 15% who are potentially life-threatening. It's good that about a third of them are cyanotic, so the pediatrician and the neonatologist will not miss it. He would be able to diagnose the degree of cyanosis and put a pulse oximetry. While the others are the potentially fatal cardiovascular malformations, they might pass asymptomatic and the baby would be discharged, not diagnosed with congenital heart, and deteriorate, die even before coming to emergency rooms. So the group of critical congenital heart diseases that we are going to discuss today are the ductal-dependent lesions. And these are two big groups. Either the duct is supplying the pulmonary circulation, like the severe tetralogy of Fallot, critical pulmonary stenosis, or pulmonary atresia with intact ventricular septum, the highest lethal and mortality in it, or it's a duct that's supplying the systemic circulation. Severe aortic valve stenosis, severe coarctation, and the end of the spectrum with an interrupted aortic arch. So we need to train our neonatologists that they have to have a high index of suspicion because it might mimic or resemble the respiratory or sepsis in newborn. Baby might present with severe cyanosis or respiratory distress, shock, or prolapse. How would we differentiate clinically when the baby is born? The ductal-dependent pulmonary circulation would present mainly with cyanosis, while the other group would present with shock. And these are the most that might pass unknown, and the mother might lose her baby without even recognizing that he has a very high critical congenital heart. I'm going to start with a group of congenital hearts like this. This is a 3D fetal echo. As you can see, the right ventricle, left ventricle, and the aorta is coming anteriorly from the anterior ventricle, the right ventricle, and the pulmonary artery is coming from the left ventricle, which is the posterior ventricle. So how would the fetal echo and this help us in proceeding with the life of this baby? By doing a Rushkin procedure. And fetal echo would help us in putting a spectrum of the transposition of the great arteries intrauterine to know if that baby is going to need a prosteen or rather an immediate Rushkin that he would benefit much from it. A lot of us as consultants would have calls from our fellows saying we're increasing our prosteen, but the baby is not improving and deteriorating. And this is one of the big spectrums in transposition of the great arteries with restrictive interatrial communication. We have two clues intrauterine that we could delineate these cases, looking at the flap of the Tatum parament ovale, and in 52% they're rather flat, a lot more than aneurysmal, getting into the left atrium, or putting your pulsed wave Doppler on the pulmonary vein and having a high of a gradient of around the cut edge of 40 centimeters per second. So I would predict that this baby, when the fetus is born, that we're gonna do the Rushkin immediately, and I usually do it in the first few hours after birth, couple of hours. Now, in developing countries like us, we don't have the whole good program of putting the babies on prenatal echo detailed and then transferring them. So I would go always that the best incubator is the mom, the pregnant mom, and let her deliver in the tertiary center instead of putting the baby on Prosteam for a long time and then losing him, because it would give us even more complications and rather than like a sepsis appearance for the baby. What I do that we go with the balloon atrial septostomy and go with our balloon transvenous, go through the right to the left atrium and try to make a hole in the heart for the mixing of the parallel circulation of the detransposition of the great arteries. If you find intrauterine an echo of pulmonary atresia with interventricular septum, as you can see here, the right ventricle is totally hypoplastic. There is no intracavitary even space for the heart to fill. A tricuspid atresia and this very small pulmonary artery compared to the aorta. So that's a pulmonary atresia with interventricular septum. And looking at it later in different views, we cannot see it looks like a monopartite right ventricle. So there is no pushing for the blood into the pulmonary artery, with later on developing during gestation a pulmonary atresia with intact ventricular septum. And looking at okay, and then now we have different shapes of and different origins of the patent ductus arteriosus. We take the baby in the cath lab in the first couple of hours after stabilizing the baby, and then putting a stent, putting an angiography in the cath lab, going through the aorta and delineating where the ductus arteriosus is. Inflating the stent into the ductus arteriosus would allow the fetus to leave the cath and leave the NICU and go home for a later growth for the pulmonary arteries and later growth for somatic growth for gaining weight, till putting a bridge till we go into with a surgical intervention. And this is a tetralogy of Fallot, one of the commonest congenital heart diseases that we see. And as you can see, an apical 4 chamber, and moving forward, you would find an overriding aorta and a small pulmonary artery relative to the size of the aorta. And I would play the video again so you would appreciate the overriding aorta with a smaller pulmonary artery coming compared to it from the side. And there are the overriding with a smaller pulmonary artery and the diagnosis of tetralogy of Fallot. So we sometimes put a stent for these tetralogy of Fallot. Usually we choose the cases that have very small pulmonary arteries and very low weight. And these are the ones that having severe cyanosis till they go to later on for surgical repair and allowing them for more growth for the baby. So intervening the early first few hours after birth would give us a chance for the baby to grow and for the pulmonary arteries to grow later on and do a total correction. Tight coarctation of the aorta. As you appreciate here, the heart is very big, and we go from the arterial side, and it's a myopathic heart. Putting the balloon into it and trying to inflate it till we do a total surgical repair later on. So we choose the most critical patients that we have with very depressed myocardial function, that they cannot go into surgery, and try to inflate it and just let time for the baby to grow later on. Okay, semilunar valve stenosis are one of the very promising ones when we find it intrauterine, and it's easy to diagnose. We have a lot of parameters that we can use. One of them is the thickened, of course, malformed valve, the doming, the systolic doming of the congenital aortic stenosis, putting Doppler, it might be over 1 meter per second. And then we would have to look later on several times, because the semilunar valve stenosis might even progress during intrauterine life. One of the things that we do know about congenital aortic stenosis, when it's a very severe one, it might even progress into a hypoplastic left heart syndrome. So we need always to keep an eye on it. And for here, intervening very early in life and going with a balloon, a very small balloon, and trying to open the valve till the baby can later on grow more in his life. The echo for the pulmonary valve stenosis, or the thickened pulmonary valve here, as you can see, and the post-stenotic dilatation, we can find some aliasing. It might or might not be present, but if putting the pulmonary valve on the Z-score, we're going to find that it's much smaller than the aortic valve. It might progress into a pulmonary atresia at the end, so we need to be aware of this. If it's a critical pulmonary valve stenosis, we would take him into the cath lab immediately after delivery and try to open this valve later on with a Tyschik balloon. Another lesion that we have is very critical, is the pulmonary artery atresia, and this we can do with, we can delineate it intrauterine with no prograde flow in the pulmonary artery. And after delivery, we would do a radiofrequency ablation for him and perforation of the pulmonary valve. So we can survive this baby with a biventricular repair rather than a univentricular repair later on with a Glenn, and later on with a Fontan surgical repair. So in conclusion, we do know that every fetus deserves a life. We have a very high morbidity and mortality of these patients. So the better, the earlier we diagnose with a proper detailed fetal echocardiography, the better the pre-planning and diagnosis and explaining for the families, and for us to be prepared in the cath lab immediately in the first few hours after delivery, without putting that baby into the hazards of transportation. And it needs a multidisciplinary approach with a pre-planning for the neonatal intervention and surgery. And the better preparing, I always tell our fellows, better preparing the general condition of the baby, of the newborn, the better the outcome will be for us later on for this baby. And avoid the transportations for long distances with its complications and deterioration of the baby when he presents to us once delivered from a faraway place from the cath lab that we have. This is one of my patients. He had a pulmonary atresia and he had to put a stent. And as you can see, he's very healthy. Now I think he's around 2 years old, and did his total surgical repair and surviving well, having a good quality of life in later on. And thank you very much.
Thank you so much, Professor Sahar, for this very nice demonstration and presentation. It's really amazing how you help your sick fetus, preventively to avoid any further long-term complications. That's amazing. Before we go to the second speaker, Dr. Abbas, before I will let Professor Rima to introduce Dr. Abbas, we have a description, a very brief description video about our fellowship program. We are going to play it to answer some of your questions regarding our online pediatric cardiology fellowship. Hello, everyone, and welcome to our Pediatric Cardiology Fellowship Program, which is very unique, wholly online flagship program structured as 3 modules, 16 weeks each. Every week you will have lectures, journal club, interviews, clinical case scenarios, and case-based discussion. And we gather several pediatric cardiology expertise from all over the world to deliver high quality materials for you. Again, this fellowship is not structured to be a monologue or based on one-way education, but it's rather dialogue, and we are involving our fellowship in the learning process because we know that one-way education through giving lecture and reading will have very limited retention rate, but we are going to try to involve you and engage you throughout the whole fellowship with a lot of discussion, demonstration, audiovisual, and we'll try to help you to implicate and try to adopt this knowledge in your clinical practice to improve your patient's outcome. Again, all the scientific material will be released on a smart platform on a weekly basis. All of our fellows will have credentials using their password and username to log into the smart platform, and they will have the freedom to navigate throughout the scientific materials during the whole year. But they need to turn in their assignments before the end of each week. All of our fellows' activities are monitored. All of their assignments and tasks will be also monitored in the platform, and there will be a quantitative and qualitative evaluation of our fellows, not only based on their scores, but also based on their engagement and their overall performance throughout the whole year of the fellowship. Again, one of our major target of this fellowship is to identify our weaknesses and limitation and to work on our strength and to let you to master the field of pediatric cardiology. Again, we are doing this through a very smart e-learning process. So wherever you are, whenever you are, you can access this material and learn throughout the whole year. And the mastery is to include and adopt this knowledge in your clinical practice, and this is our target. So module 1 of the Pediatric Cardiology Fellowship is going to focus on the core knowledge and the basic principles of pediatric cardiology, starting from the basic cardiac anatomy, physiology, embryogenesis, pharmacology, common pediatric cardiology problem like cardiomyopathy, myocarditis, heart failure, rheumatic heart disease, infective endocarditis, and the major emphasis will be given on the pediatric cardiology diagnostics, especially cardiac MRI, CT, echocardiogram, chest X-ray, and of course, EKG. In Module 2, we are going to focus on the pediatric cardiology main topic of acyanotic, cyanotic heart disease, and the neonatal cardiology fetal echocardiogram. And in the Module 3, we are going to be more advanced and we'll talk about the electrophysiology and different kind of arrhythmias and pacemakers, perioperative and cardiac critical care, and pediatric cardiology interventions, including the mechanical circulatory support and heart transplants. So this fellowship is accredited by the American Association of Continuing Medical Education for 96 credit hour. So all of our successful fellows will receive their graduation certificate from the American Association of Continuing Medical Education. Again, please try to apply and take advantage on the early 10% discount using this promo code of webinar 10 that is going to expire soon. Again, the knowledge has no value unless we put it into practice. And the great aim of education is not the knowledge itself, but the action. Our aim is to improve our standard of care and our patients' outcome. So our fellowship is starting tomorrow. All of our fellows who already applied are going to receive their first week materials tomorrow morning. If you haven't joined yet, please feel free to do. We still have a couple seats. Now it's time for Professor Rima Badr to introduce our second speaker, Dr. Abbas Kashnook.
Hello. Having problems with my
You have
computer.
two devices open. Professor Rima, please turn off one of them.
Yeah. I have, I don't know what happened to the computer, but anyhow, I'd like to introduce our next speaker. I enjoyed the first talk, and the second talk is by Dr. Abbas. Dr. Abbas, be kind enough and introduce yourself, because I don't have the data to introduce you. I know that you're a well-known figure in the Emirates, and you basically trained in the UK. Could you please be kind enough and introduce yourself?
No problem. Thank you, Professor Rima, and thank you, Dr. Amar, for giving me this opportunity. My name is Dr. Abbas Krishnud, and I'm a consultant pediatric cardiologist and specialize in heart transplantation. I did all my training in the UK, and I've been leading on one of the transplant centers in the UK for over 10 years in Newcastle at the Freeman Hospital. And recently, in the last 3 months, I have relocated to the United Arab Emirates and been taken on the lead role to set up the pediatric heart transplant services in the United Arab Emirates, especially through Abu Dhabi. So I bring a lot of experience from heart failure in terms of not only primary management in heart failure, but advanced heart failure management, including use of mechanical support devices like ventricular assist devices, and then assessing children for pre and post-transplant workup. So I do practice in that area apart from just general cardiology. I also specialize in advanced imaging in form of cardiac MRI. So that is one of my additional imaging roles, which complements the work that I do. So thank you all for being part of this excellent seminar, and hope you enjoy my talk. Good evening. Welcome and thank you for attending this next session of the series of exciting webinars organized by the World Institute of Critical Care and Emergency Medicine. I would like to begin by thanking Dr. Amir Al-Husseini for providing this excellent opportunity, creating a platform to share knowledge and experience across the globe. My name is Dr. Abbas Kushnud, and I'm a consultant pediatric cardiologist and transplant physician, recently moved from the UK to Sheikh Khalifa Medical City Hospital in Abu Dhabi. The topic today is from antenatal diagnosis to delivery room action and beyond, where timing defines survival. Dr. Sahar has eloquently set the scene for pre- and postnatal interventional management of children diagnosed with congenital heart disease. In the next 18 to 20 minutes, I will aim to cover 5 key areas: the global landscape of congenital heart disease and the antenatal detection rates. This is important as we have clinicians and healthcare professionals attending this webinar from different parts of the world, and clinical care can highly be variable. The role of antenatal diagnosis and the risk of stratification, and understanding the hemodynamic severity in each cardiac lesion. Delivery planning and immediate stabilization. This will include duct and non-duct dependent lesions. Then we will follow this with a real-world high-risk case study, hypoplast left heart syndrome with restrictive septum. We'll look into the outcomes, both short-term and long-term. This is particularly important in different countries across the globe. And finally, a slide on outcomes of the future using AI. One cannot have a talk without mentioning AI these days. So let's start with some factual figures about global congenital heart disease populations. As one can see, there is a significant global variation in cost and detection rates. For example, cost ranges from $3,000 in India to over $300,000 in the US. Detection rates mirror systems maturity, ranging from below 20% to over 80%, as seen in the last column. This highlights a key point. Outcomes are not just clinical, they are system dependent. In more developed systems, like in the UK, hypoplastic left heart syndrome detection rates reaches 80 to 90%. Other lesions like TGA, complete AVSD also are detected early between 60 and 80%. This demonstrates what is achievable with structured screening, skilled imaging, and integrated pathways. Let's start by understanding the importance of antenatal diagnosis. It enables informed parent counseling, clear decision making, and allowing parents to understand that their baby may require an intervention, palliative care, or comfort care. It transfers care from reactive to proactive, which is where we see the highest gains in the survival and quality of postnatal care. The study below highlights the increase in number of patients deducted with major CHD once their antenatal program was established. Accurate antenatal diagnosis depends on standardized views. The 4-chamber, outflow tract, 3-vessel views, all typically done between 18 to 22 weeks gestation. Correlation between genetic and other conditions is also important. And finally, understanding physiological changes between the fetal and postnatal period is highly important in managing patients postnatally. Delivery planning is built around the 5 key areas which form the pillar stone of risk stratification: antenatal counseling, the severity of congenital heart disease, the mode and place of delivery, post-delivery stabilization, and need for cardiac intervention and surgery. Let us begin the risk stratification depending on the severity of the congenital heart disease. While several categories have been described, I have stratified patients into 4 levels of care. Level 1, minimal risk routine care. So these are typically patients with left to right shunts like a VSD, common AV canal, mild valve disease with no critical stenosis, or some forms of arrhythmias like SVT, heart block, which are not hemodynamically significant. The baby is delivered routinely with a standard care and often transferred to the nursery or a special care baby unit and may require an echocardiogram before discharge. Level 2 are usually duct-dependent lesions requiring more monitoring. This would be variants of hypoplastic left heart syndrome like underdeveloped left outflow tract, moderate aortic stenosis, where you might require duct initially to assess the condition, coarctation of aorta, for example. Tautology of Fowler, usually Ping fellows might not require duct, but occasionally you might have to start with prostaglandin initially to assess the severity of pulmonary stenosis. And most of these patients are again born around 39-40 weeks gestation, would be under the care of the neonatal team for commencing prostin and transferred into the neonatal intensive care unit initially, and then, if required, into a cardiac center. Level 3 is moderate risk, needing urgent intervention. So these are patients with transposition of the great arteries where mixing at the atrial level is not clear. It might be patients whose function might not be great, either secondary to a complex congenital heart disease or possible cardiomyopathy. And while they can be planned deliveries around the term time, you would require the neonatal and the cardiac teams to be ready at the time of delivery. The patients may require an urgent cath procedure in form of balloon atrial septostomy in TGA, or might require some surgical intervention very early on, and the patient might need to be moved to a cardiac center immediately. And finally, level 4, which is the high-risk cases, require immediate specialist input and good planning. This would be patients like severe hypoplastic left heart syndrome with a restrictive septum. Occasionally, if you have been able to pick up an obstructed anomalous venous drainage before birth, then that can be planned, and the patient is either delivered to a maternal center very close to a tertiary cardiac center, or even planned within the cardiac center with a full team ready to deliver the child at the center for immediate intervention and even need for surgical backup like ECMO support. Some centers can also make their risk stratification on the basis of different lesions. So for example, in this table, you can see that the risk stratification is on the basis of the cardiac lesion specific. So you can see in first row, you've got pulmonary atresia with an intact septum, or a DORV with a pulmonary stenosis, critical AS or PS, transposition of the great artery with intact septum, or an anomalous pulmonary venous drainage. And these are all duct dependent lesions. On fetal echo, if they've had an antenatal scan, that would be confirmed with the echo findings. This would be categorized as level 3 or level 4 according to our previous risk stratification. And postnatally, the patient would require starting prostaglandins, immediate stabilization, and then transfer to a level 3 center for both cardiac intervention and surgery at a later stage. Then you could have a slightly less risk acquired lesions. So that could be tetralogy of Fallot with severe PS, which might make it duct dependent. A possible coarctation, but you might have large duct and not sure whether this is evolving coarctation or not, related to various arch issues. You could have a double outlet right ventricle with a normal arch, and that might just not require any duct dependent circulation after birth immediately. So the duct dependency would be variable in this category. You would look at what the echo report shows in terms of the flows, whether the duct flow is abnormal, whether there is some obstruction. Often this is level 2 category where you need observation immediately after birth, cardiology review before transfer to the cardiac center if possible, so and certainly before discharge, and then depending on the outcome, arrange follow-up accordingly. And the third category would be the very sort of level 1 or level 2 lesions, which are left to right shunts mostly, or tetralogy of Fallot with a pink lesion where you don't require duct dependent circulation, or like we described, some mild arrhythmias in the previous slide. So none of these lesions would require prostaglandins to keep the duct patent, and then they can just be transferred to the postnatal ward, can have an echocardiogram just before discharge or early cardiac follow-up, and often these are electively discussed later as the baby grows older for cardiac surgery if required. So if we look at the last 3 key areas, we can approach the postnatal care in 3 phases. It is dependent on the center-based pathways, the available infrastructure, and availability of tertiary center and transplant facilities for that particular center. So the phase 1 would be antenatal phase, where you have a diagnosis already in hand and reported with a plan postnatally. You have the delivery phase, where you would plan the delivery and where the patient would be delivered either close to a tertiary center or can be done at a level 2 center, and postnatally in terms of management after the baby is born. All 3 phases would require multidisciplinary team approach, and it's very important that all the active team members are part of this discussion. So this next slide, which is a flow chart, is probably one of the most important slides in this talk. The flow chart will illustrate how decision making translates into action. So if we go towards a classification of 3 types of heart disease that would be diagnosed antenatally, from severe, moderate to mild to low, that becomes a starting point of how you would manage post-delivery. So in case of the severe congenital heart disease, you would be expected to have an immediate emergency delivery plan, a planned induction most likely as a C-section, and once the baby is born, it is either repatriated immediately to a tertiary cardiac center, and the transportation is all arranged in place. This will involve the multidisciplinary team in terms of having the obstetrician who will plan the delivery, the neonatal team which would be taking the baby into care straight after birth, the cardiology team which would be involved pretty much immediately depending on the complexity of the cardiac lesions, either at the delivery center or within the tertiary cardiac center, and the intensive care team who would be looking after the baby post-birth depending on the type of procedures or interventions required. The transport team, as I mentioned, is highly vital, and this would vary significantly depending on the region and the practices in that area. And finally, not to forget the important nursing team, which would be involved on both sides, from the delivery side to the receiving cardiac center. Often this transfer can happen postnatally, but sometimes you might require in utero transfer, so the delivery actually happens in a tertiary center. Then if we go towards the moderate congenital heart disease, often they happen at a neonatal intensive care unit facility with level 2 or level 3 care. So the delivery is planned, the baby is born and transferred to a neonatal intensive care, and then depending on the type of cardiac lesion, it might follow the pathway of a severe CHD and immediate repatriation to a tertiary center, or it might be stabilized and then at a later stage transferred directly to a cardiac center. Now, in both these categories, you may require immediate IV access. Definitely need to start prostaglandin in most of these lesions, making sure that all sort of access is available, and an echo is done immediately after birth to confirm the antenatal diagnosis. Now, if the moderate category of congenital heart disease is less intense, may likely to be less duct dependent, then in that case the patient would go into a neonatal intensive care unit and stabilize, might require prostaglandins for duct dependency or not, and then transferred to a cardiac center for review. Or if the patient is very stable and has had a complete echocardiogram on the neonatal unit, then can be discharged and seen as an outpatient review. And finally, you go to the mild or low category congenital heart disease, where often babies are born and then electively transferred to a postnatal ward or a special care baby unit in level 1 centers sometimes. And then if the baby is very stable and there is no surprises, then often the baby gets discharged and moved to a cardiac review center. We have to remember two categories within this complex flow chart. One is the preterm deliveries, so babies which are less than 2 kilos. Now, regardless of the complexity of the congenital heart disease, often these babies are managed on the neonatal intensive care unit. Most cardiac centers would struggle to take babies less than 2 kilos birth weight, and often that initial stabilization with the cardiac lesions continues to remain on the neonatal intensive care unit with the advice and informed plan from the cardiac team till the baby reaches a certain weight size to allow further cardiac interventions possible. And we also must not forget that some babies with really complex lesions may not be suitable for any intervention and might just have to go through the pathway of palliative or comfort care. And often in those scenarios, the babies stay on the neonatal intensive care unit where the comfort care and the counseling is provided to the family without any further cardiac intervention. So as mentioned in my previous slides, I have used hypoplastic left heart syndrome with a restrictive septum as an example of tri-phase planning, which is antenatal, delivery, and postnatally. So what is hypoplastic left heart syndrome? We all know that there's underdevelopment of the left heart structures of the heart, including the mitral valve, left ventricle, aortic valve, ascending aorta, and the aortic arch. You can see some echo images of the underdeveloped left heart structures in the three cartoons on the right. Though it is less frequent, it still forms about 1.5 to nearly 4% of congenital heart disease diagnosed in babies. Unfortunately, about a quarter of these babies will not survive the first week of life, and this is very much dependent on the type of variation in the hypoplastic left heart syndrome category, the type of antenatal diagnosis, planning, and postnatal approach. It is important to remember that a lot of genetic syndromes can have the association of hypoplastic left heart syndrome or its variant, and it can form about 10 to 25% of the infants having this as a diagnosis. So what are the red flags that need to be looked into antenatally and then planning your delivery and postnatal management? So if we start off with the three variants of the hypoplastic left heart syndrome spectrum, you have mitral atresia with aortic atresia, you can have a mitral stenosis with a small aortic arch, or you can have mitral stenosis with aortic stenosis and the arch is of a reasonable size. Now that allows you to then determine the anatomical variations and how you would manage that. From a pathophysiology perspective, there are two key areas to bear in mind. One is the anatomic elements, so you need to make sure there is an unrestrictive duct and an unrestrictive interatrial communication to allow for good prognosis. And the physiological elements, which comprises of the pulmonary venous the pulmonary vascular resistance. So QPQS, which is the flow of blood to the lungs versus that to the systemic circulation, is very important, and you need to put that into perspective with good systemic output to allow a balance of flow for both the circulations. So what are the worst prognostic elements antenatally? So on the fetal echo, if you see fibroelastosis on your left heart structures, that becomes quite an important negative prognostic factor. The degree of AV valve regurgitation, so if you've got quite a leaky valve, that might make your postnatal management more complex and difficult. The type of variant, which we've just highlighted on. Any additional shunts, like the coronary sinusoids. Pulmonary blood flow, which is quite important in the context of both the pulmonary and systemic circulation. We talked about the interatrial communication. And finally, any secondary pulmonary lung changes, more importantly, something called the nutmeg lung, as you can see in this image at the bottom, and is a very poor prognostic feature of hyperplastic left heart syndrome with a restrictive septum. So after birth, one of the important things that you will come across in this category is left atrial hypertension. So obviously the lung becomes quite congested. There's element of pulmonary edema. There is reduced lung compliance as a result of secondary lung changes. You end up having severe hypoxia or hypoxemia. Rapid acidosis as a result of both respiratory and metabolic acidosis. Severe cyanosis, and all of these interventions may require intubation and ventilation and duct-dependent prostaglandins straight and immediately after birth. And if the mixing is not great, you need to try and open up the interatrial septum as soon as possible. Now, all of this can lead to additional organ injury, so not only your heart and lungs, but other organs start to get affected if the interventions are not timely. Now, regardless of your antenatal planning, delivery planning, and postnatal immediate care, this category of cardiac lesions still involve a very high risk of morbidity and mortality. So one needs to be ensured that all the relevant steps are taken promptly, but also that the antenatal counseling with the family and parents is appropriately done to factor the high risk of mortality in this patient category. So in this lesion on fetal echo, you would see a significant A-wave reversal on the pulmonary venous Doppler, a restricted interatrial communication flow pattern as shown in the echo images, and all these patients would require serial fetal echoes to assess not only the cardiac lesions, but also to monitor the fetal growth, well-being, and extracardiac anomalies with a view to plan a high-risk physiology immediately after birth. Here we see a complex environment with a planned delivery for a patient with hypoplastic left heart syndrome and restrictive interatrial communication. The prenatal goals were well defined and the family were well informed about the possibility of a postnatal and long-term complicated journey. At 32 weeks, the wider team has been involved with the delivery planning. The patient was delivered at a surgical cardiac center, especially if you do not have a maternity unit very close to a cardiac center. Prompt stabilization was instigated with making sure the patient is intubated and ventilated. Prostaglandin was started, and on echocardiogram, the anatomy was confirmed. There was immediate intervention in form of atrial decompression post-delivery. A balloon atrial septostomy was undertaken very swiftly. Occasionally, you would require these patients to undergo a septal stenting to make the atrial communication wide open for a long period of time, and not to forget the surgical backup with the need of ECMO in these cases. And despite robust planning, it is important that the high risk of morbidity and mortality has been counseled with the family, because despite all the intervention and timely measures, the outcome can be quite poorly in some cases. So following a successful delivery planning and risk stratification, let's look at some of the outcomes. In this graph, you could clearly see that if no intervention was planned, then the survival is very low. And even if it is delayed, that reduces the survival to around 40% compared to early intervention and planned delivery, where the survival is around 70 or higher. So if you look at this table and compare the outcomes of certain cardiac lesions and how they can be improved, many conditions now exceed more than 90% as a result of good antenatal detection and planning. However, if you look at hypoplastic left heart syndrome and single ventricle disease, they still carry a very high long-term risk. We must also focus not just on the survival, but lifelong outcomes and quality of life in these patients. The map below highlights the variations in global outcomes, which shows a huge disparity depending on the socioeconomic status. This study clearly highlights that if antenatal diagnosis is done early in major conditions, the survival is much better in a planned environment. The two together reinforce the need for standardized pathways, capacity building across different centers, and a global networking to allow for good outcomes in all patients with congenital heart disease. This final slide talks about AI and AI-driven diagnosis for the future. In this multi-center, multidisciplinary international study, the prenatal detection of CHD using deep learning-based imaging and video analysis was undertaken with a protocol called CARE, which is Clinical Artificial Intelligence in Fetal Echocardiography. The primary outcome, making large database available using ultrasound images of normal and abnormal fetal hearts. Secondary outcome, to collect clinical data to determine the effect of clinical parameters on AI-based model performances. So hopefully that will improve the detection rates, reduce the variability, which we have highlighted in the previous slide globally, and support clinicians not only in decision making, but also affecting the outcomes for the better. Thank you for attending this session, and I hope I have provided some insight into risk stratification of different complex congenital heart disease and how good planning could influence your outcomes. Thank you once again, and I'm happy to take any questions.
Thank you again, Dr. Abbas. It's this beautiful presentation from a heart failure renowned figure. And Dr. Najib, you've just joined us again. And do you have any comments on the two beautiful talks?
Yes, of course. Thank you for Professor Shetta and Dr. Hashnoud for these talks. Really appreciate every single item of the presentations. As an interventionalist, I would like to also introduce this very specific important point in position of the great artery, where not only being born in a tertiary hospital is important, but also the timing of the Rashkin procedure could be life-saving. Sometimes the interventionalist team have to be present at the delivery room. And there is a way to understand why. Very simply because when the foramen ovale is very restrictive, and this is something we can see beforehand during the fetal echo. But when the atrial septum is very, very restrictive, there is something very important that goes on, and please follow me for a second. So what happens in this case if there is no large VSD? The right ventricle will be outputting its flow to the ascending aorta. This is transposition. Even if you give prostaglandin, there will be overflowing of blood to the lungs. All this blood is returning to the left side, to the left atrium. It is not mixing to the right atrium and right ventricle, and therefore, this is recirculation to the lungs. From the ascending aorta to the PDA to the lungs, returning to left atrium, back to the left ventricle, back to the pulmonary artery, back to the lungs, back again to the left atrium. What's going to happen? You'll end up with low cardiac output, low kidney perfusion, and low saturation, just because there is no recirculation to the right side, which is the systemic side. So it's very important in these cases to be diagnosed prenatally. And the team would be present at delivery room or close to the delivery room, and the cath lab personnel be present for immediate Trashkin or almost immediate Trashkin. Professor Sar, you mentioned during your presentation the PFO.
Sorry, can I just comment on this, Naguib? This is beautiful, but let me add to what you said. So intact interatrial septum or restricted interatrial septum is, as you said, critical case antenatally. And this can be diagnosed by various means, not just the hole. We measure the flow, the Doppler in the pulmonary veins, and we see the ratio. And then we can say antenatally that this baby is going to be you can do an operation or not, because if the pulmonary bed is hypertensive, no matter what you do, this baby is not going to survive. So we do also maternal oxygenation test on the mother and see if the pulmonary bed will respond to oxygen. So this is the maternal hyperoxygenation test for 15 minutes. You give mother 100% oxygen. So restrictive intra-atrial septum, as you said, a long time ago, they know it antenatally, and they say to you, cath lab people, this is going to be in a hybrid. The delivery is going to be in a hybrid suite where the delivery room is next to the cath lab. And you either do septectomy, because these septums are usually very thick, or you do whatever you can do. And you have sometimes to have ECMO standby. Just wanted to add these things. And the lesions that you can get them is hypoplastic left and transposition. And as you kindly and beautifully said, that the flow will be affected and you will not get, but the lungs will be overwhelmed antenatally. Thank you.
Exactly. I do have a question to the
If I may add, I had for just from the educational perspective. Can you hear me?
Yes.
Sure.
Okay, so for the doctors, we have two very simple parameters during doing fetal echocardiography, and we have the flat septum, as you just mentioned, Dr. Najib, is around 50% had the specificity and sensitivity for a restrictive interatrial communication. And we have a cut point value of 40 centimeter per second by putting our pulsed wave Doppler in the pulmonary vein to know if this patient is gonna be a very highly critical patient or he would benefit immediately in a hybrid setting for a balloon atrial septostomy. And I think this is one of the adding things for the detailed fetal echocardiography, that we started putting a spectrum for the transposition of the great arteries, whether they are at the high risk or the low risk patients.
Thank you, Doctora. Beautiful. I'd like to also use the expertise of Dr. Abbas in heart failure. Now, we know that we diagnose heart failure in utero.
That's right.
And this is important. And I was trained by the guy who made the cardiovascular profile score, Jim Suter, and there's like a 10 out of 10 or 7 out of 10. And he says that you get every point 2 points, and if you get a 10, you don't have heart failure. And if you have 7 out of 10, you cannot be delivered through the vaginal canal. What do you think, as an pediatric heart failure specialist, what do you think of the heart failure in utero? You think we can treat or we cannot treat? Because this is a controversial point.
Yeah, I think in my experience, it's very challenging to treat it in utero because the circulation is very different. And the moment the baby comes out, that completely changes over. So sometimes even if you take some interventional steps in utero in terms of managing the heart failure, we have seen that postnatally, the whole picture is very different and you still end up with quite significant cardiomyopathy to deal with if indeed it is quite bad. Often because of the way the fetal circulation is, you have very less worries about afterload at that point. So till the baby actually comes out, you don't see the actual effect of the afterload that the left ventricle will have to go through. So that in itself becomes a bit of a tricky situation prenatally, because you might do some interventions, but you might have to still be quite cautious when the baby's out.
So I can add to this. Usually in utero, it's the right side which is really
Between,
giving us
exactly.
everything about heart
Is
failure.
dominant, absolutely.
Yeah, and heart failure, we measure it in the right side, and we measure it in the venous flow and the IVC flow and the ductus venosus and whatever. So what we do, and some schools would agree to buy time in utero. So we give DIJ in special doses for heart failure, and this is where you get the cardiovascular profile score below 8 or so. And we buy 1 or 2 weeks, not more. So I think I'm in favor of that because it's really harmless. But if you have a lesion like Epstein or whatever, or high drops that come in 20 weeks, we don't. But if it is 32, 33, we try to buy time. So I'm just saying heart failure also in utero could be addressed somehow.
Yes, absolutely. I think if you've got extremities like hydrops or Epstein's, then I think that's a completely different sort of an analogy. But if you're worried about primary cardiomyopathy, which is sort of there as a result of what you see in the changes in utero, then I think taking those initial steps is definitely worth it.
Thank you.
May I ask the speakers a very important question about counseling parents in cases with severe outcomes, even after 1, 2, or 3 surgeries, like hypoplastic, depending on availability of those surgeries, intensive care, and interstage care available in the city or the country where you are working. Things are different.
Yes. I can go first here. So I think antenatal counseling has become quite important, especially in the way things are managed now. So when you have an extreme congenital heart disease, certainly my experience in the UK has been that a lot of counseling would happen along the lines of using heart transplantation as your final palliative stage process as well. So you might also have a counseling process where you say, yes, you're going to go through the 3-stage palliation if you're looking at a single ventricle anatomy, or you've got a complex and a congenital heart disease where you think the surgical outcome is going to be challenging. And then a lot of centers have now used that as a very early on counseling mechanism to use that. And not only antenatally, even postnatally, when you get the baby and it's diagnosed with a complex congenital heart disease, and you might be able to give some sort of palliation, there is sometimes an early indication to say that maybe your end goal as a palliative treatment might be a heart transplantation rather than just going through the conventional surgical procedures. So yes, the counseling has moved quite, obviously it depends on whether your center or the country has the capacity and the facility to provide transplantation as an option, but I think that is certainly taken the way forward now.
Saha? Dr. Saha, you are muted. Unmute yourself, please, if you want to reply.
Okay. Can you hear me now?
Yes.
I think it differs from one country to the other. It differs according to culture and religion. And as Dr. Asif just mentioned, according whether they have a heart transplant program or not, if they're doing a Norwood procedure or not. So I would go more towards the developing countries. We do not have right now a Norwood going on program, Norwood operations, neither do we have a heart transplant. So what we do is our medical consultation with the hypoplastic left heart with a very high incidence of mortality postnatally. And then comes the religious part, and they would go and talk to whether a sheikh is a Muslim or a pope or a rabbi, whatever they have, and then they would take the decision. In Egypt, we do not allow miscarriage even after 12 weeks. And I know that in United Arab Emirates, they're putting another law now, I think Dr. Abbas. So the hypoplastic by itself is a controversy in different countries, according to the programs they have, the facilities, the religion, the cultural background. So it differs from one place to the other.
Allow me to add to what Prof. Sahar said. we had just a beautiful webinar on the fetal series under Congenital Heart Academy a few days back, and we had around 15 or 19 worldwide panelists to discuss the guidelines and other things. So the concept in regarding the hypoplast left heart syndrome, one first thing is a spectrum. So we cannot deny people surgery, or not all of them will go to along the Fontan route. Some of them will have catheter intervention at first week of life, and then they can sort of find somehow stage 2, and maybe the Fontan is a difficult one. But what I'm saying here, consider the spectrum, and I quite agree with Dr. Sahar, with Prof. Sahar, is that the background, the facilities is very important when you counsel. Now, going to the Sharia law, or what we have in most of the Muslim countries, is that you are allowed to get rid of the baby up to 19 weeks gestation. And so nowadays, there's a verse in the Quran that says, "La yurja bur'u." It means that there's no hope in recovery. They allow termination or induction of we can say ending the life before 19 weeks. It is allowed. And in Saudi, you have to get the approval of 3 consultants. And so it is happening quite a lot. Now, this is for the hypoplast and other lesions. Even nowadays, they're getting this for the Down syndrome. So from other cultures, other backgrounds, you have to go, and the patients will have to go back to the culture or religious aspect. But the message here is that, yes, counseling depends on the resources available in the country, plus of course, which is number one, what the parents think of keeping or not keeping the baby. And this is the chance antenatally. I get nowadays counseling at 13, 14 weeks of parents who had a previous hypoplast, scared of having a hypoplast. And we tell them their recurrence risk is higher in the next pregnancy, but it is not going to be as 1 in 4 or autosomal recessive or autosomal dominant, whatever. It is still under process. So counseling is very, very important, considering resources and ethnic and what the parents want.
Very well. I'll have a final question, after which Dr. Husseini has a final word. So we know once the baby gets to the correct and to the right center, to the right team of surgery, intervention, and physicians, everything should go as best as possible. Once we have the good diagnosis in utero, we know where to direct those patients. My question here, at least in the Arab world, what is the rate of misdiagnosis by gynecologists or by radiologists who do the first scan of babies? We know not all babies end up under the echocardiography by fetal cardiologists. So what is known about this missed rate of misdiagnosis?
You're using the wrong terminology. It is the detection rate of congenital heart disease antenatally. Now, the webinar that we had in the fetal series in Congenital Heart Academy, you can watch it on the YouTube. Everybody is talking about the low detection rate antenatally. So it is very difficult for many reasons. One of them is that we don't have a system in most of the Arab world to scan, compulsory scanning of pregnant ladies at 18 to 20. So like in Canada, you go as routine 18 to 22 weeks. But in most of the Arab countries, East, West, or Central, whatever, there is not such a system. In the private sector, yes. Detection rate depends on the first liners, who are the sonographers or the obstetricians or the pediatric cardiology fellows, or whoever, depends on the system. If you're North American, or if you're a European or UK based, it depends. So detection rate depends on training, very important, and training is not as good. We have to do something called screening, and screening is also not very good. Detection rate in most of the Arab countries is 0 to 20%. Detection rate in America is 60% to going up to 70 to 75%. In some of European countries like France, detection rate antenatal is going up to 80%. So I hope I did answer your
Rima,
question.
I'll stop you for a
And
second.
if I
Just a
may
second.
add something.
Let's see it from the other end. You are cardiologist now, the baby is born, and you have a number of complex heart disease, congenital heart diseases. How many of those have been detected previously as opposed to none? Are you
You
saying
want to go
Okay.
lesion by lesion?
And
You want to go lesion by lesion? Lesion by lesion, the most detected one is the hypoplast.
No, those who need
okay.
level 3 or level 4.
Yeah, the
Okay,
easiest one to diagnose is the hypoplast, single ventricle, right or left.
Yeah, and transposition.
Transposition, no, you can miss. This is one of the tricks. That's why they asked us to do outflow tracts. In transposition, if you do the 4-chamber without outflow tracts, intact septum, you can easily miss. It's one of the mostly missed. However, it's one of the best lesions tackled antenatally. It did help quite a lot in the outcome once you diagnose them antenatally. As you said, with the septostomy, cystectomy, whatever they do, and surgery, first week of life. Yes, the success of antenatal programs was shown in transposition. Sorry, Prof. Sahar, I'm sorry I did interrupt.
Okay, Dr. Naguib, Professor Rima, Professor Naguib, thank you for your questions. But let me just say what I do, being our efforts as taking Egypt or Cairo University, being the chief of the fetal cardiology. Let me tell you what we're trying to do, Dr. Naguib. We conducted a diploma for the screeners for the obstetrician, the fetal-maternal medicine, and we've graduated several classes up till now. We're increasing our success rate for prenatal detection now. They are the first screeners, but we are, of course, the referral, but for them to detect the baby, and we're increasing the percentage now. I think it was around 6 to 7%. To my knowledge, the last one became around 22%. And the people who are interested are the fetal-maternal medicines, the obstetricians, ultrasound, and the radiologists. And we have now a new entity in the radiology for the woman care. I took this even to a higher level. Excellent. I took this even to a higher level to the government, and we are initiating a project for training all the obstetricians, ultrasonographers in the 27 governorates we have in Egypt, so as to detect. As Professor Rima have just mentioned,
I think we have to circle this around because this will be an endless discussion, excellent discussion. We can talk about it
But
forever.
we must congratulate Sahar on this really project,
Take
good
notes
project.
of our speakers. Please call them. I'll circle back to Professor Al-Husseini for the final call and final word. Thank you very much.
Thank you so much, Professor Najib, Professor Rima, and of course our great speakers, Dr. Abbas and Professor Sahar. By the end of this meeting, I'm very glad to have this very thoughtful discussion, and because this is very critical, challenging situations that doesn't only involve the mother or the fetus, but probably affects the whole family and our community. This needs multidisciplinary team and teamwork is the key. It's very hard for single physician to take this critical decision. So I think we are all here to help with that, and with this very informative discussion. I think this was part of this educational process. So I really appreciate your contribution. So for the attendees, again, thank you so much for staying with us for almost an hour and 20 minutes. So by tomorrow, you should receive the recording of this webinar on our YouTube channel. So we'll share it with you. By next week, you're going to receive the certificate of attendance of this webinar. If you haven't joined our fellowship and if you are interested, please go ahead and do it. We already put a lot of information about the fellowship in the chat box. If you have any questions, concerns, inquiries, please feel free to reach out. And with that, I wish a happy rest of your day, or rest of your evening, whatever rest of your night, wherever you are.
Can I just interrupt? I'd like to thank you. Also, I'd like to say, please join the fetal series on the YouTube. And we have 43 fetal webinars with most prominent educators worldwide. And our last 2 days ago session is very important for you worldwide, where we discuss the guidelines. Are we following guidelines? Are we not? And what our colleagues said, detection rate of congenital heart disease. Please feel free. And these are free webinars together with today's fantastic session. I wish you all a beautiful learning process and going home in peace. Thank you.
Thanks.
Thank you, everyone. Until next time.
Thank you. Bye-bye.
Okay, thank you very much.
Bye.
Okay, bye.
Bye.
Bye.